One of the techniques for location of the femoral head, especially in a difficult to scan patient, is to actually use the bone anatomy to guide you down to the hip. When we start scanning, one of the favorite techniques or preferred techniques is we can start at the anterior inferior iliac spine, and sitting just superficial and attaching to the anterior inferior iliac spine is the direct head of the rectus femoris tendon. So following the bone structure, I'm going to slide the transducer slightly inferior and medial, so the anterior inferior iliac spine is going to slope away. Then I'm going to get into the flat portion of the acetabulum, and as I continue the downward projection, we're going to see the rounded portion of the femoral head, and I know I'm on the femoral head because of its configuration, but also you can see the cartilage that is adherent to the femoral head at this point. Now, sitting just superficial, sliding the transducer slightly back up onto the acetabulum, you're going to see the area of the short axis of the conjoined tendon of the iliopsoas. Now, this is a nice area or projection if you're going to be doing an injection technique into the area of the iliopsoas. If I slide the transducer slightly medial, I'm going to see the femoral artery and vein, which are structures that we certainly want to avoid during any type of injection technique. So as I slide my transducer medial, I can see the pulsation of the vessel of the artery, I can see the femoral head, and I can see the area of the conjoined tendon sitting on top of the acetabulum. Moving the transducer slightly lateral again, the approach for injection into the iliopsoas would be from a lateral to medial, from a superficial to deep approach, and approximating the needle in the area of the iliopsoas tendon structure in its short axis. This is a good way to avoid any type of the major arterial or nerve structure in the anterior part of the hip. Now, one of the techniques that really helps to give us a wider field of view is I can actually open up the transducer aperture using the virtual convex, which gives us a slightly bigger field of view and may assist us in following the needle from the more superficial portion as we come down onto the area of the conjoined tendon of the iliopsoas, sitting right here. Femoral head is our bone structure. Turning the transducer from the short axis, a nice technique is to point the area of the transducer landmark or orientation marker to the contralateral shoulder. So as I simply turn the transducer in a clockwise fashion, I can get down to the area of the anatomic location of the anterior capsule of the hip, and I would be able to guide my needle into that anterior capsule from a lateral to medial approach. The orientation marker at this point is approximately between the patient's contralateral ear and shoulder. Once again, the technique: slide the transducer up, turning the transducer in a counterclockwise fashion, finding the anterior inferior iliac spine and the direct head of the rectus femoris, sliding the transducer inferiorly. We'll pick up the ridge of the acetabulum. We'll see the iliopsoas tendon and the rounded head of the femur. To get into the position for the injection to see the femoral head-neck junction, I simply rotate the transducer in a clockwise fashion, keeping the femoral head in view, and until I see the typical landmark of the femoral head-neck junction, and I can see the capsule of the hip sitting just superficial to that area.